Hello and welcome, everyone. My name is Renee Garrett,
Yeah.
and I'm your speech therapy PD podcast
Oh,
host for Brainstorms, functional neurorehab for SLPs.
select a speaker. There we go.
Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non financial disclosures. The financial disclosure for Kim Neely is that she's the owner of the Trauma Informed SLP LLC. She receives an honorarium from Speech Therapy PD for participating as a guest on this podcast. Her non financial disclosure is that she's a certified trauma support specialist through the Arizona Trauma Institute, a donating member of the Autistic Self Advocacy Network, or ASAN, ASHA 2022 and 2023 presenter on trauma informed care, professional burnout, and neurodivergent affirming practices. Kim is also a member of the LGBTQIA plus community and an HDER.
Mm.
My financial disclosure is that I'm the owner and founder of BrainBridge Connect LLC and is the host of Brainstorms and other webinars on speech therapy PD. I do receive financial compensation. I'm an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat box for the Q&A and will be answered at the end of the presentation. Now, without further ado, we welcome our guest, Kim Neely, MM, MS, CCC, SLP, who is a practicing speech-language pathologist who brings a unique blend of clinical expertise, musical training, and neuroscience curiosity to her work. Before entering the field of speech-language pathology, Kim was a mildly successful opera singer and voice teacher. She earned her Master of Science in Speech-Language Pathology from the University of Arizona, where she was honored with the Jean R. I'm going to try to say it correctly. Goleen Outstanding Graduate Student Award. Despite not being accepted into graduate school in her first try, Kim went on to pursue doctoral level coursework in neuroscience, driven by her deep interest in brain science and admittedly hyperfixations. Kim identifies as neuroqueer and is passionately focused on trauma-informed care. During the COVID-19 shutdown, she completed a graduate course on the topic, which was her version of a sourdough starter, and continued her training through Trauma Institute International, earning certification as a Trauma Support Specialist, CTSS, which she maintains through ongoing education. She's pretty okay at being an SLP, but exceptionally committed to making the field more informed, inclusive, and brain savvy. Kim, so good to see you.
Hey, thanks for having me. So excited to be
First.
here. Seriously.
Yeah, it's been a
Yeah,
while. I haven't
I
seen you since
know.
Seattle.
I know. It feels like that. Gosh, that's almost a year. Almost. Goodness.
I know. It's been a year. I don't know about you, but it's been a year.
It's been yeah, a year, the equivalent of 10 years. It feels for sure. Uh,
Well,
well,
let's
thank you for,
start.
yeah, go
Oh
ahead.
yeah, no. I was gonna say let's start with we'll jump right in. I know that you're the pro here on the basic physiology of the emotional system. So if you could just
Sure.
start with explaining that and then, whatever you're comfortable with jumping into survival modes, or if you just want to keep it at the basics for the start.
Yeah, either whichever way it goes. So yeah, the survival mode stuff we'll probably get into for sure because for trauma-informed care, I mean, personally, it might just be the neuroscience geek in me, but understanding more of how our emotional system works and then the survival mode aspect is sort of one of the keys of how trauma changes our physiology. So
Mm-hmm.
that's a pretty good for me, it's a good basic level of understanding at the individual level what trauma informed care means for the people we treat and then for ourselves and for anyone we're around. And then really on the path to becoming more trauma informed, you take that knowledge and you apply it more to groups and more at the system level things. So I always think it's a good idea to start with that. And I know people who aren't as into physiology kind of about that, but I think it's still a useful thing to know. So,
No, I agree. I agree.
you
It's
know,
you have to know the basics for you to understand the whole concept really and to understand why it's important for us to know.
yeah, exactly. And it definitely has connections to communication and how we interact with each other and all of this. So it does have a really big, I think, a really big piece to play, even though The human data is lacking, but it's still important. So I usually like to start from sort of sensory information up to the brain and then back out again. That's kind of my way to go. So I like to start with the autonomic nervous system, which, just to review, that's the one that is in charge of all your automatic processes, essentially. It's kind of in the name there. And it has the two different branches. So this is the one with the parasympathetic and the sympathetic. And the parasympathetic is known as the rest and digest system. And the sympathetic is the fight or flight or freeze system. And we always think of the motor output, the rest and digest and the fight or flight, as kind of the motor output of that system. But it also has sensory. It carries a lot of sensory information into the brain through this nervous system. So the sensory side of the rest and digest system, the parasympathetic, that one's carrying a lot of just kind of current state of how it's going, regulation information in terms of like, how much energy you've stored from food and your body temperature, your heart rate, like just the status quo, right? It's kind of keeping the Excel spreadsheet of all of that. And the sympathetic system, the sensory information that one carries is if things have changed, essentially. So acute changes in the body. So if you stub your toe, that feeling of pain before you're consciously aware of the pain, it's that change went up through your sympathetic system. And so when we get up to the brain level, I'm going to go ahead and skip by all the brainstem stuff because, phew, it gets tricky up in there. But all that information from those two different branches end up going to the amygdala. Ultimately, that's one of the first main stops on our limbic system journey here. And the amygdala is, we've heard about it and it kind of gets a bad rap. A lot of people like to think of it as the thing that makes us angry. But in reality, the amygdala is one of the highest, or perhaps the most connected part of your brain. It's extremely important to have. And its main job is to appraise the incoming stimuli coming from your autonomic nervous system, among other things. The amygdala does a lot of things. But it definitely will appraise it. So when you stubbed your toe, and once that information gets to your amygdala, you're still not consciously aware that you stubbed your toe, but not yet. But it'll label that stimuli as, hey, we don't like this. This is not good. Right? And the other thing to know about an amygdala is that when it appraises the value, it also has direct connections to your hippocampus, which we recognize. That one's a big one for, of course, our memory stores and recall of memory. And the amygdala hippocampus connections are where we tend to encode our emotional memories. And it's actually the fastest long-term memory encoding in our brain. It happens incredibly quickly. Just to understand how quickly, I usually think of, if you've ever gone to a restaurant and you got some food poisoning there, and then like 2 or 3 or 4 years later, somebody says, let's go there again. And your brain is like, I'm not eating there again. No way. Right? Because that long-term memory got encoded really fast. I also think this might have a little something to do with why we think of like first impressions mattering as well. It might have something to do with that. And so amygdala and hippocampus, of course, they can encode those memories. And then the amygdala also has direct connections to your hypothalamic nuclei or hypothalamus. And that's essentially kind of the boss of all your hormones. It's the one that releases what is called tropic hormones to tell the other glands what to do. So it's kind of the did you get that memo boss of your endocrine system. And that's also important to know because the amygdala can really trigger things hormonally in your body really quickly if it needs to, if it determines it needs to. But just in terms of how the stuff works, we'll keep trucking up to the higher level stuff. So that was sort of our midbrain. And then the last two little aspects are our higher cortical areas and our neocortex. We have the anterior cingulate cortex, the ACC. And this one is this is essentially where you become aware of the emotions you're having. It also has a really big part in signaling an error between what your amygdala thought was going on and what actually happened. So our brain is always trying to predict things and predict patterns, of course. And so the anterior cingulate cortex will signal an error to the amygdala like, hey, you valued this as a big issue and it actually wasn't a big deal at all. That's one of its jobs. So the ACC and the amygdala actually talk and give a lot of feedback to each other pretty much all the time when you're not in a survival mode, I guess I should say. Caveat. Spoilers, we're getting there. The other thing that I think is good for us as speech language pathologists to know is the anterior cingulate cortex has direct connections to our Broca's area. So
Hmm.
if you can't get an awareness for your emotions at this level, you can't really talk about them either. It's sort of unreasonable to expect someone to talk about them if they're if they can't even get a conscious awareness of what they're doing. And there is a name for that. That's called alexithymia, and it's present in trauma victims and also present in a lot of neurodivergent brains, the inability to kind of label our emotions or recognize those in others. But I get a little bit ahead of myself. So let's go right back into our neocortex areas. So we have anterior cingulate cortex. We also have our insula, which is that little tucked in cortex in that temporal area. And we don't have a whole lot in humans anyway. Most of the data we know about what separates ACC from insula is really more lesion studies. It's usually if people have had damaged insula. But we do know the insula has something to do with emotional processing, and it seems to have a really important role in our emotional side of our empathy and our compassion. And I do want to caveat that because I know on social media, everybody talks about compassion and empathy and people not having it, but there is a cognitive side. So you don't have to have intact emotional empathy that doesn't mean you completely lack it. You can have a cognitive empathy as well. But yeah, so we know that the insula has something to do with those things. And other than that, it seems to overlap a lot with the ACC, essentially, as far as we can tell. So yeah, and like I said, that's the big thing about, the higher level, these neocortex areas and the midbrain areas talking back and forth with each other, just chatting when we are in a nice, like healthy, regulated, not in survival mode type state. It's working kind of optimally, right? And what also happens in the body, thanks to the connections and the output to our autonomic nervous system through things like the hypothalamus and such, is that we end up with a pretty regulated nervous system as well. Our autonomic nervous system's in balance. So we have sympathetic and parasympathetic activation. It's not like a one's on versus one off. It's just more like one's dominant over the other sometimes. And they just kind of, you can think of it like a nice balanced seesaw or a nice little pendulum swinging back and forth as you need it. And for those of you out there who happen to work with mental health providers, if you have direct work with them, they talk a lot about the window of tolerance. That tends to be the main thing they talk about when it comes to autonomic regulation or emotional regulation. So this is just a model, a way of thinking of healthy autonomic function over time. So you get, sympathetic, like right now, since I'm going through all of this, I probably am a little more sympathetic dominant than I was, 30 minutes ago. And after I'm done, I'll probably crash a little, have some food and rest and digest, and have that be a little more dominant, right? And when our autonomic function works this way, it means usually our emotions can correlate with that as well, just through that extra pathway up into the ACC. So we want emotions to be able to ebb and flow, just like our autonomic system. They should come and go in a really manageable way. Emotions are relatively, ideally, fairly transient. That's kind of what you want with that. But so this is where we get into the survival mode stuff, which is how we get into understanding our physiology of trauma, because it comes out of this. So when we go under threat, what tends to happen is the amygdala gets the information that, and it'll appraise it as, oh, something's wrong here. We're under threat. This is bad. The amygdala can actually tell the hypothalamus immediately to tell the endocrine system to release like your adrenaline, your epinephrine, all of that stuff. You can go straight into it through that. And it'll probably tell the amygdala, we're encoding a threat here. So we need to know about this. Like when you had the food poisoning, similar kind of idea. That's definitely a threat to our potential survival, at least, prior to modern medicine and such. So when we go under threat, what tends to happen is your brain/body is going to choose one of the three survival modes. And it depends on the environment you're in at the time and your past experiences and your known skills. So it's not like we really just go into one or another. It's more just context dependent. So for example, if you happen to be like me and you're not a super huge fan of spiders, if you if you see one crawling,
What?
some people like them, but hey, and I know they're useful. They're useful to our ecosystem and all that. I respect them, but I don't want them near my bed, right? Like I don't want to see
Fair.
one in my bed or crawling near my bed. And if you're about to go to bed and you see one there, you might go into survival mode, but your brain also might pick fight because you can probably stomp that spider. You can probably kill it, right? Or catch it or something. You can do something. You can probably
Catch
beat
and
it.
release.
Yeah, exactly. Like somehow you'll get out of that situation, right? Whereas in a different situation, maybe let's say you're attending a talk or something and the fire alarm goes off in the building. Well, now you'll probably want to flee. You'll probably want to evacuate the building, right? Or get away from the fire. Like most people don't have the instinct to like punch a fire. That's not usually the way our brain goes, right? So,
I like that.
unless you have a fire extinguisher, I guess then you can fight the fire. But most of the time, we think get away from fire, right?
Yeah.
And so freeze mode is a good one to know about because freeze mode is the one that happens if your brain figure decides that neither fight nor flight works, freeze is what you go into. And it's good to know about because freeze is the weird one for people to talk about later on because they're still very conscious of what happened. They have a conscious memory of what was going on, but they feel very disconnected from their body. That tends to be what happens with freeze. So it's like a dissociative. Basically, their higher cortical areas are still alert and aware, but the midbrain is actually running the show. So like their upper brain is like, I don't even know what's happening. I'm not even getting any sensory information or anything. But freeze is essentially what happens that, yeah, if you can't run away fast enough and you can't fight, you'll go into freeze. Also, good for folks who work with kids to know kids tend to go into freeze more often than fight or flight, which some people, I know, I think Vanderkolk in his big Body Keep Score book, he says it's probably because they don't have the life experience. But then part of my brain is like, it's probably because they're also very tiny. Like, when you think back in like Neolithic tribal times, there's probably very little in the natural world a child would be able to run from and or fight. So it makes sense
Right.
that, right? Like it makes sense to me that their brains would be more wired for like, I will just freeze and be an inanimate object and you won't touch me. Where I live, there's a lot of wild rabbits. You see them out here. I call it doing their rock impression, where they just freeze. That's a freeze response. That is a freeze. So it's not playing dead, it's just frozen. And so that's an important one to know about. And then I have started mentioning flop because in autistic community especially people are mentioning flop as a potential survival mode. It's not in the literature if you look into human studies on survival. I'm including it just in case 20 years from now you never know what might be in there. But essentially this is where people report a loss of muscle tone. It's effectively kind of like passing out. They're not in control of their body at all. This would be, in my mind, a little more akin to playing dead, which the human studies say humans don't have. But I wouldn't be surprised if maybe there's some humans who have it. And honestly, I'm just thinking outside the box. I'm just sort of thinking like maybe this has to do with people who pass out outside of blood. I don't know. Maybe it might have something to do with that. You never know.
Well, and the freeze
Yeah.
thing too, I think,
Mm-hmm.
and sometimes with adult survivors of trauma, they
Mm-hmm.
often will have dreams and then the dreams they freeze.
Mm-hmm.
And that's those times
Yes.
when you can't scream,
Yep. Mm-hmm.
you wake up and you realize you were trying to this. I probably shouldn't talk about my childhood trauma, but I know.
It happens sometimes, it comes up. Yeah.
Yeah, but that was
Yeah.
for a long time. That was a dream that was a recurrent one for me, was like trying to scream for
Mm.
help and I couldn't
Mm.
scream.
Yeah.
So,
Yeah. And that actually happens to victims as well when they're in the freeze response. They won't be able to
mhm,
scream for help. And it's very common for people who have some sort of interpersonal like violence enacted against them. They might
mhm,
feel ashamed for not being able to fight back. Like, I didn't
yep.
fight back. I didn't scream for help. Why didn't I do anything? I was just there. I don't know. I couldn't do anything about it. And that's an important thing, which we can talk to in a bit. But I was actually with a high school student at one point who was telling us about things, and we got a counselor in there quick. We were like, we need some help because she is telling us about some very serious trauma happening here, which was a similar thing. She froze and she was feeling really ashamed about it. Like shell shock, a little bit, a little kind of. Yeah, I can talk about that in just a second. Shell shock is kind of the old term for PTSD for
Yeah.
vets.
Yeah.
Yeah.
And that's what I was going to say, is that freeze.
Mm-hmm.
I think one of the reasons that as an adult neuro rehab provider, it's so important for us to be
Mm-hmm.
aware of, because a lot of my patients with TBI or even with stroke that
Mm-hmm.
have communication disorders, they will often experience this because they've had this prior trauma and now they've had this
Mm-hmm.
new trauma, and it's like they can't get past it. And that's why we need to
Yeah.
know about it, because
They
it can
they get kind of
happen.
stuck. Yeah.
Yeah. In your therapy room. And then you're like, what do I do?
Yeah.
Yeah.
Exactly. Yes, I should probably just bring this chat up. I keep seeing things pop up here. Oh,
I know.
yep,
And I
that's
said, we'll wait till the end, but some of these are
good
pretty
point about the
relevant.
ADHD. Yes, I will actually get to that in a second. But yes, that is something that does get ADHD and PTSD have a lot of overlaps with each other. So does autism actually and PTSD as well. So especially when you get to complex PTSD. So we'll get into that for sure. But that is definitely, if you have those moments where you feel like you can't focus at all and because of a survival mode thing or because of a trauma trigger, it starts to mimic that ADHD I can't focus thing, even though
Mhm.
speaking as an ADHDer, my brain just works very, very differently. So I have both, not to brag, both trauma and ADHD. Uh, yeah, woohoo! So fancy. Which I make
Trauma and
I
PTSD here, so it's fine.
yeah, it's great. It's fantastic combo. Which I've tried to explain that to my friends because I know my friend was like, "How do you know it's not the trauma?" And I'm like, ADHD is like I have Olympic level like table tennis matches going on in my head with like 50 different balls all at one time, all the time. That's not the same thing as trauma, though.
Yeah, no.
Like it's like no, trauma doesn't cause that. That's just how my brain always works. I saw something the other day where somebody talked about how like it was like one of those ADHD content creators somewhere. I think they're this British couple in ADHD Love, I think is their thing. Anyway, they're great, but the guy was talking about something about like how when he's just sitting still, it's like his brain is just quiet. And she's like, "What do you mean? Like, what are you thinking about though?" And he's like, "No, it's just quiet." And she's like, "Yeah, no, but like it can't actually be quiet. What are you thinking about? Like you have to have thoughts. It's just always thoughts." And it's like, yeah, that's kind of how that works. Always thoughts.
Yeah, I think the only, and I don't even think that's, I was going to say the only time my brain is quiet is when I'm sleeping, but that's also not true. So-
It's like buzzing around everywhere. I know, right? So, yeah, I can definitely get into that. And just to give me a second, guys, I'll get into like, let me get through the survival mode stuff real quick, because then I think hopefully it'll start to clarify some of this stuff. But the other thing I like to mention with these is a fawn response, which I call a fawn response and not a survival mode, because fawn response is when you've probably already had an experience that caused some sort of threat or some sort of adversity or something that was not a good situation where you felt unsafe. And so fawn response is when you start to create emotional safety by just trying not to upset anybody. Like you're going to people please, right? So this is like, cis women definitely like saying yes to things when you don't want to, not feeling safe to say no in certain context, right? Like it's definitely part of that. And pretty much anyone part of any level of marginalized group likely have some type of fawn response within that group that's just sort of an expected behavior, at least when you're
Mhm.
not around other people in that group. There's probably some kind of expected way of like, I'm not a dangerous version of so and so, like yeah, I'm fine, kind of a thing. And personally, I think that neurodivergent masking is essentially a form of a fawn response. That's like a
Mhm.
neurodivergent way of just trying to get included and trying to be safe because we are communal creatures. That's another thing to always remember, I think, is that humans, we need community. We don't survive. We're not man versus wild. That's not how our species survives. And so we're not tigers. We don't just mate and go away and go do our own thing forever. Like we build communities. And so emotional safety and psychological safety also play a key role in that because in order to feel safe with a community, you have to feel like these people have my back. And if
Mhm.
you don't belong, or they tease you or they bully you or they throw you under the bus, you don't feel like they have your back. So it makes sense that that lack of safety and fawn response tends to come more from that feeling a little more, can be physical too, but okay. So when we get into these survival modes, let me get back to, hold on, sorry. I can, once again, ADHD, I can go off forever on other tangents, but all right. So what to think about when you go into survival modes is this is where we get into how it sort of connects to trauma, because going into survival mode doesn't guarantee a trauma response. But you have different processing speeds, right? So you have like, your brain stem's pretty quick, your midbrain is a pretty darn quick place, and so is your neocortex. But really, neocortex is the slower processing speed compared to all these other areas in our brain. And when you go into a survival mode, obviously you want to go fast, gotta process really quickly. So what tends to happen in survival mode is your amygdala essentially will stop listening to your anterior cingulate and stop sending a lot of information up there too. It might send some, but not a ton. So we call it downregulation. So your upper cortical areas get downregulated because it's a little too slow to make quick decision making, which kind of makes sense. If you're facing a bear, you don't want to sit there having to think about the pluses and minuses around possibly fighting or not fighting the bear, right? Like you got to react faster than that. Yeah, so it makes sense. But that's also where we get into things like freeze response, where when people have that conscious awareness, the frontal area knew what was going on, but they might not feel their body. They might not be able to put into words what actually happened. They've just like, there's just some sort of weird blank where it feels like their body got taken over. This is also where people talk about getting like the tunnel vision. I mean, part of that is our adrenaline and the way it reacts with our eyes and all of that. But this is where the survival modes feel different. Things feel slowed down. Things feel, that's hormones plus the fact that our conscious brain is still aware, but it's not in charge. So it feels like we're just kind of watching as almost like a movie kind of a thing. And so the best we know of how a trauma response ends up developing from all of this is that the longer the downregulation lasts, right? So the more our conscious awareness and our midbrain are disconnected from each other, the more our emotional memory is disconnected from our semantic memory, right? So what ends up happening is that the amygdala isn't going to get an error detection anymore, right? So if it keeps throwing you into fight, flight, and freeze over and over and over again, then it's not going to get a correction for anything. So one of my examples for this would be like for, say, like over here in Colorado, I know prior to the Malibu fires, we had a big wildfire thing out here called the Marshall Fire where people lost their homes and such, right? And luckily nobody perished and everybody, which was amazing because the wind was incredibly fast that day, but people got evacuated in time. That all worked great. But I also knew people who would still have this triggering from the smell of the smoke. They couldn't get away from it, right? They were around the smoke so much, even after evacuating and then worrying about their homes and then still continuing smell of smoke and stuff. So if you're in that state where you just, because you're still smelling something or because you still hear something, even if you're in the ambulance or you're in the vehicle and you're going to be actually physically safe, if you that might just keep kicking you into the survival mode. So now things get really hypersensitive, right? And your parasympathetic system over time will become kind of sluggish. So it's hard to have the rest and digest system come back on. It's slower to come back on. People spend a lot more time in sympathetic dominance. And so the net effect becomes that the sympathetic system is just on most of the time. And people call it being hypervigilant or what have you. But that's where you're stuck at. And your body might try to kind of rebalance, but it really can't because the mechanisms it usually uses to get itself back into balance are just too disrupted. So people just kind of get stuck in this all too easy to trigger a threat response again, and they get thrown back into survival mode, which is when you talk about shell shock, especially when we talk about like 4th of July fireworks, they sound like bullets. So people who've been in war zones where they've heard the sound of bullets, which is a genuine threat, obviously, they might get re-triggered by that sound because it's that emotional memory triggering. And if their body goes straight into survival mode and you get the down regulation of their conscious brain might still know, hey, I'm safe. This is 4th of July. These are fireworks, but their body is going to feel like they need to do something, right? Either hide or something. They're going to go straight into that survival mode again, which is what's called a trauma trigger. That's what people really that's what a trauma trigger really is that emotional memory being triggered of a survival mode and then having all the same down regulation happen and everything at the same level, essentially, that it happened the first time. And so mental health folks have something in the window of tolerance. They have a different way of looking at it where they say it like it's narrowed, but basically you end up in either being hyper aroused or hypo aroused. So you end up with like super sympathetic dominant, like you go into anxiety, panic, anger, sleeplessness, racing thoughts, which also can sound like ADHD, those sort of things, that kind of stuff. And then you also have this hypoaroused, which the old model, if you ever hear, I don't talk about polyvagal theory very often because it's been disproven, just so you guys all know, if you've ever heard that one, I don't tend to talk about it. That theory said, oh, maybe hypoaroused is more rest and digest. I don't think it is. I think it's still sympathetic dominant. And it's when essentially your energy stores are depleted.
Mhm.
So you might have those racing thoughts and then anxiety and that panic for a while, but at some point you're going to burn through all of that. So then you go into a shutdown phase and like kind of numb, kind of empty. You feel lethargic, you feel withdrawn. You just want to lay on the couch and stare at a Netflix show and barely even register you're watching it, right? In that sort of state. Not that that was me after at the end of the school year, when I worked in
Or any of
schools.
us in healthcare after COVID. Yeah,
Oh my
fine. It's
Lord,
fine.
yes. Oh my gosh. No, seriously. Oh my gosh. Yeah, healthcare was just, oh, I know. I had switched to schools before then, which I was like, hey, that actually worked fairly well, but still, and there are just days in general where you just feel that burnout so hard that you're just like, just flopped, you know?
Mhm.
And so this is where you get into that's what essentially dysregulation looks like in the autonomic system is like just this constant up and down, and you never really feel at peace, you never feel calm, you never feel rested. You just feel like you're just constantly moving from like super crazy frantic energy perhaps to like super crashed energy possibly. And I always like to say this because I know, especially when it comes to regulation, if you ever work with kids and also TBIs, honestly, same thing. They can
Yeah.
definitely have dysregulated autonomic system, which can be additionally stressful for them if they remember being a calm person. And then they're like,
Mhm.
why am I getting agitated so fast? And it's like, I know they remember being calm, but well, I used to explain some of this to my TBI patients just in terms of like frustration levels and agitation and this sort of dysregulation is, and it's part of the healing and like, and so just to give them some understanding of like why you feel like you can't hold back your emotions, why you feel like suddenly these things are agitating you. This is part of what happened. Your midbrain is got a little jostled, got a little damage there. It's got to kind of reboot and clean itself up and we'll work on it. But, just to get the panic away from like, why? Why do I feel this way? You feel like you're going crazy,
Yeah, or the
you
people that
know?
panic because they can't remember what happened because they were in a trauma
Yes,
response trying to keep their body alive versus trying to
exactly.
recall the event. That one's a hard one to
Exactly.
explain. Yeah. And then
Mm-hmm.
also the neurochemical transmitters that are disrupted because of
Mm-hmm.
the trauma, but also hormonal disruption because of
Yes.
yeah,
Mm-hmm.
yeah. And
Mm-hmm.
it's important for us to be able to explain that, but to our patients in a more simplified way because a lot of those pieces are
Mm-hmm.
difficult for them to kind of hold on to. But also, you're dealing with someone who may have attention and memory issues now from their cognitive stuff from the brain injury,
Mm-hmm.
plus executive function disorder. And so they can't
Yeah.
hold all these pieces of information.
No.
So it's
Yeah.
really good to have like a simplified version you can pull out of your pocket to talk through
Mm-hmm.
your patients and their caregivers with because they think it's their fault.
Exactly. Right.
Yeah.
Yeah. Like they should be able to fix it somehow. And it's like,
Mhm.
no, not yet anyway. Yeah. And I mean, usually my simplified is just talking midbrain upper. Like I tend to sort of break things down a little with the visual, but I also used a lot of times, I think it's the therapy insights people have that like scale of like, it's like cognitive effort or something
Yeah.
like that. I use that a lot too, because the other thing that's good to know for amygdala, especially if you work in neuro rehab stuff, is that the amygdala is really connected to our attention networks too.
Yes.
So if you're stressing their attention or their working memory, they might start getting frustrated. And that's, I think, one of the reasons we get frustrated, like neuroscience wise. This is sort of me extrapolating. So I might be right. I don't know. But I think one of the things that might be the issue is that it makes sense to me that in the sense of human, I always try to think like way back when we were cavemen, what did we probably do? What do? Essentially, right? Because it's like, well, these survival modes have been around since then. So we got to know sort of what it would be like back then. And I'm thinking, back in that day, if something came out, if your attention centers were stressed so much that you couldn't be aware of a potential threat, that probably would put you in a threat. So it kind of makes sense that frustration comes from stressed attention in my mind in that sense. Like it might throw you in a bit of a survival mode to be like, I can't pay attention to any of that right now. Like I'm too much. And it's like, that makes sense. That makes sense. To really
Yeah. And
focus, we want to be safe, you know? Yeah.
well, and I think, one of the things that we wanted to talk about was how this knowledge of how brains respond to these types of things is
Mm-hmm.
how that applies to marginalized groups, how
Yeah.
that, systemic adversity in marginalized groups, how it really plays a role. It's a
Yeah.
huge part of it. And if you're,
Huge piece.
we're
Mm-hmm.
working with all, for me, I'm working from people that are 17, 18, all the way to geriatrics, and you're working with
Mm-hmm.
school based, but you've worked in the past with adults. And so,
Mm-hmm.
a lot of us work in very different realms and different practice settings, but the principles are the same.
With all people. Yep.
Yeah, and
All kinds of people.
we see
Mm-hmm.
things with people even when we're not in the therapy space, right? It could be
Mm-hmm.
something
Mm-hmm.
within your own circle, or like stuff happens at the grocery store here. I don't know why, but there's always some weirdness going
No.
on. Or like
Oh.
yesterday we went to, no, it was this morning. We went to the grocery store, and it's one that we go to every now and then. It's known for really good prices. We went in there and we're
Mm-hmm.
like, what in the world is going on in here today? Like, what is happening? It was just a
Oh
weird,
no.
very uncomfortable like setup. I
People
don't
getting
know.
very stressed out in the grocery store, I guess. I don't
Yeah,
know.
like it's
Ugh.
just get your blackberries and almonds and keep it moving.
Yeah, that's true. I know. It's like, why are we having the freak out in the grocery store? What's happening here? Yeah, no, for sure. Which does bring up a good point. That is sort of the one of the way trauma informed care often gets sort of summarized is the like, instead of thinking of what's wrong with them, think what happened to them. But I will admit, sometimes I'm still thinking, listen. I might know, yeah, this is survival mode, but come on, you're in a grocery store. Ooh, it's okay.
Yeah.
The sky isn't actually falling, right? Like, shh, it's cool.
Yeah, or like last week we were
Yeah.
in, we had
Yeah.
the hurricane off the coast, and it was like
Oh yeah.
I made a post on Facebook because around here, and it's probably everywhere, but it's like people go to the grocery store and they get all the bread, milk, and eggs.
Oh yeah. I grew up in Augusta, Georgia. I remember the bread and milk runs for
Yeah,
any
it's like
weather event that
what
might
do you
happen.
yes,
Mhm.
what do you need bread and milk? I mean, bread I get, but like milk,
I never quite
I'm
got that
not
either because, like, first off, milk
gonna
goes
drink another
bad.
mammal's milk. Gross.
Yeah. Yeah. I was always like, why are we getting perishable milk to like survive off of? I don't know. That doesn't
Right?
make sense. It's gonna go bad at
Yeah.
some point, right? But
Because
yeah, I know I
around
remember
here,
that
if
in
we have,
Augusta, if there was any snowfall at all, they would be like, bread and milk, that's it. And it's like,
yeah,
who
and
has been
here it's
snowed in
like
Augusta, Georgia? Really?
there's usually two things you're gonna lose: water and power.
Yeah, right?
So,
Yeah, it's
and
like,
it's a
no.
thousand
Yeah,
degrees when it, yeah, anyway. Oh,
I know.
wow, I
I
got really
agree.
off
It's like,
topic.
yeah, no. Understandable though. People make some strange decisions when it goes into survival mode because that upper brain just is not getting to weigh in on the better decisions usually, which makes, I guess it makes some amount of sense, but it's also like, yeah. So when we think of systemic stuff, if we take this individual, now we understand, okay, we get into the survival mode, our autonomic system gets kind of thrown off. Oh, and I also just wanted to share just really quickly about regulation. We always think of regulation as being calm, but that's not really what it means. Regulation just means your energy can match whatever situation you're in, right? You don't always want to be calm. If you're on a roller coaster, you don't want to be resting digesting on a roller coaster, like eat your funnel
You know,
cake after, right? That's why you don't give the kid the funnel cake before riding the rides. It's after you ride the rides. You don't want to
yes.
in that situation, right? But I think we think of calm a lot, especially for us and also in the schools and stuff, because that's where people learn. So when you're sitting and learning, it makes sense. We want calm to help learn in that setting, but it doesn't have to be always. All right. So when we get into systemic stuff, so basically taking this up to the systemic level, you have to think about societal adversity and how society gets structured in a way that becomes a threat to certain people. And honestly, quite frankly, to most of us, let's face the facts. Most of us are not billionaires. I'm assuming on this particular call, we probably don't have a ton of the super uber wealthy folks in charge
Not
here.
me.
Right.
Not on that pay
So
scale.
yeah, right. It's like, I know that is one nice thing in a way. I mean, okay, look, we all definitely need to get paid more, but at the same time, it's like You never have to worry about saying like, you just have to work harder to get paid more and deserve it. Like nobody buys that in our field. It's like, don't come at us with that. Like, no.
Right.
Yeah, amount of money you make is not equal to the amount of work you do. We know this. Okay. So one of the ways I've been doing this is something for myself, and then, being late diagnosed and stuff, just having to kind of work through systemic stuff and sort of deconstruct this stuff, which it does get tricky. It gets uncomfortable. Good idea to take a breath and relax, and you're not actually under any kind of threat. If we talk about it, it's okay. We can just talk about it. But one of the ways I've been thinking about the societal stuff is I think of our society is essentially based in a hierarchy, right? Which, from what I'm a little bit of an anthropology geek, I've gotten a little bit into anthropology through this stuff. And it seems to me that pretty much any civilization that entered feudalism, we developed this hierarchy, right?
Mm-hmm.
We always had like the monarch, the king, the emperor, the czar, aristocracy, warriors, the landowners, and then you had like your workers, your peasants, your serfs, your slaves, your people out in the fields doing the stuff nobody else wanted to do. And I think although a lot of the world has moved on from feudalism, we still have the social hierarchy from it. I think that's kind of where we're at. So the United States flavor of this is essentially the colonialism and the white supremacy, those sort of terms. That's the type of social hierarchy that we've inherited from our colonial history. And I like to think of it social hierarchy because I try to stay very global with it in my mind, and historically global, because if it's trauma, it should apply to all of humans throughout humanity. So I've done some looking into history of like, East Asian cultures, for example, prior to encountering the West. And they also entered feudalism and also had social hierarchies going on there. Tribal cultures, it's usually structured very differently. They actually don't tend to have nearly the same type of hierarchy that we think of in terms of what's normal, quote unquote. And so this hierarchy is the water we're swimming in. There's sort of this way of looking at it in terms of systemic stuff when people start deconstructing this kind of stuff, is that, the discrimination, the bias, this is stuff we're just swimming in these waters, where we are raised with a very clear idea of who are the best people and who are not worthy of stuff, right? And like the idea of you have to become worthy in order to get taken care of, in order to get access to healthcare, for example, things like that. And it's like, okay, I think we're getting a little pushback finally to this idea, because it is pretty dang silly. But there's a really great image online called the Wheel of Power / privilege, where they kind of talk about, you can have some privilege that's really fluid and it changes throughout your life. So like your wealth status, your abilities in terms of your able-bodiedness. Obviously, if you work with senior citizens, we're all pretty much temporarily abled if we actually, have the privilege of living older, of living to near end of, older life there. And then some of it is lifelong, and some of it is very overt and obvious, like your skin color. And some of it can be kind of hidden, like possibly you're a neurotype, or whether you're gay or, bisexual or whatnot. If you're queer, sometimes that's overt, sometimes not. But we all have this sort of stuff. The more of it you have, the kind of lower on the society rung you are, essentially, right? And the more you get bombarded with a lot of messages that are not very nice, but also you get bombarded with a system that's not built for those people, right? The system gets rigged, essentially, for people who are determined to be the people that are the good people, that deserve things, right? And so there is something called, I know people have probably heard of the ACE study, which is the Adverse Childhood Events study from the CDC and everything, which last I checked is still up there. So that's the one where, last I checked, it's still there. I don't know, but it's well documented in other countries too. So I'm sure we'll get it back if it does go anywhere, but still. So that's the one, where they got data on adults and the kind of adverse childhood experiences they had in terms of homelessness or domestic violence, that kind of stuff. And then they found the connection. They weren't intending to, but what they found is the connection between those adverse childhood experiences and poor outcomes health-wise down the road. And in 2017, Ellis and Dietz came out with the pair of ACEs framework, where you have to include, so if you think of the original adverse childhood experiences being a tree, the adverse community environments are like the roots under the tree. So for folks who are marginalized, they can be they're born into a situation like poverty or discrimination or, poor housing, lack of clean water, right? Like this is where violence, community disruption, gentrification, essentially, right? Tearing apart their community, possibly, because that is one of the big ways that, especially for those living in poverty, that's how they survive, is with each other. So if you break apart the community, that really affects them negatively. So they put this in here because if you don't think of that, if you don't think of like the generational traumas, the historical traumas, the system-oriented traumas, you are going to be missing a very big piece of what this person's just sort of saturated in, essentially, from early on, from when they're born, right? And there's a really great quote I usually include from Resmaa Menakem, who I believe it was in one of his books, but he's also said it on other like interviews and such. But the quote is, trauma decontextualized in a person looks like a personality. Trauma decontextualized in a family looks like family traits. And trauma in a people looks like culture. Mm-hmm. Which I really like, because that is definitely a big piece of, the way a lot of marginalized groups develop community and develop culture is around survival, and it's around healing as well, trying to heal from the adversity, trying to find a sense of safety, which is the key place of where we start to heal, is when we feel safe. That's where we can start to build resiliency and heal from the adversity we've had. We have to regain that sense. That's a really key part in terms of overcoming trauma and also developing more resiliency against it. So a lot of cultures have, traditions around grieving and things like that. And that's why very likely where that came from was this grief left unmanaged can become a real issue, can become a real trauma, can really break people up and become such a problem. So, people have come up with ways to essentially start to heal from those sort of things. And so, so I think that's just an important thing to keep on the register, because, system-oriented traumas are the ones that come from like, you didn't mean to, but you accidentally said a microaggression, that can develop a system-oriented trauma or re-traumatization where we don't realize it, but we're accidentally triggering something that is negative from what someone else has heard, right? And we can't always be up on everything. Like, I don't expect us all to know all microaggressions at all times and know not to say things that might hurt, but it's good to be aware of. And then if you feel like, or you notice someone suddenly got uncomfortable, like, just acknowledging it and apologizing and being like, did I say something? I'm so sorry if I said something inappropriate or hurtful. Please let me know. And and do that sort of repair work. I think that's the bigger thing, is realizing that trigger is not about you as a person, and it's not about you being a bad person. It's more about like just being someone who can create more safety for somebody by like acknowledging it and, taking a breath and moving along. I also think it's good for us to know about this stuff, because I think there's also the internalized oppression side, which is basically all that stuff that leads us to fawning, essentially. All the, I should be doing this, I should be doing that, I shouldn't be this way, I should lose weight, I should put on makeup, I should, right? Mm-hmm. All these things that get in our head, a lot of times those things will come out with our clients without realizing it, or with our patients, especially if you're working on like social stuff or pragmatic stuff or anything like that. We tend to sort of impose what we think is normal on somebody, which might not be normal for their particular group, their particular intersectionality, right? Like, I guess a funny way to say it would be like, you don't necessarily want like the Midwest housewife teaching pragmatics to like a drag queen, like it just might not match up.
Well, yeah. And well, too, when you think about, again, often we're dealing with patients who have these existing traumas and now they've had this other event. So whether it's a new medical diagnosis of a progressive neurological disorder or a TBI or a concussion or a stroke, any of that kind of stuff where, they already had this part, that thing, or maybe there's multiple things,
right,
that's already impacted. And now we've had this other thing that's changed the response that they already had. Now it's changed again. And so that's why I think people can, I always, when I worked in inpatient rehab, and I would be like, bring me all the TBI patients, which makes me sound like a crazy person, but it was because I felt like
Yeah.
those were the folks I felt like I could try to help and like give them space. And like a lot of
Hmm.
providers would be more like, oh, I can't stand working with TBI. They don't know how to regulate and they're always so angry, or they threw their plate of food this morning, so they don't know how to participate in therapy. And it's like, you
Yeah, that's part
stop,
of
like
their, yeah,
stop. If you
yeah.
and if you don't understand the underlying part of the neuro system and why they're responding that way, and then looking at the other
Hmm.
pieces of the picture, because
Hmm.
say it was somebody who and this happens a lot where I live, like we would have patients who had been previously incarcerated and now they're in a wheelchair. Maybe
Oof.
they can be considered harmful to themselves because their behavior. So they might need safety measures like seatbelt in their wheelchair so they won't get up and walk on broken legs.
Hmm.
Or they're in a posy bed because they're not safe.
Hmm.
They don't sleep well, and they can't be up prowling at night into other patients'
Hmm.
rooms or
Right.
harming themselves or things like that. And so,
But then they're getting triggered because they were, if they were incarcerated, like you said, it's like that triggers the
yeah,
like restriction and the, yeah,
right. Yeah.
absolutely. Yeah.
Yeah, so there's a lot of layers to this that I think people
Hmm.
often just don't look at the bigger picture. They're looking at this
Yes.
isolated thing and they're not looking
Yes.
at this big ball of wax that it actually is. It's like, oh,
Right.
well, they're mad because they had to go to bed on time. It's like maybe they didn't go to bed that time. It's sort of like when you describe
Yeah.
patients in skilled nursing facilities or long-term care facilities,
Hmm.
and we hear this with our geriatric patients with dementia. How would you like it if someone told you what time to get up, what time to eat,
Right.
picked your food for you, picked your clothes for you, told you when you could go to the bathroom, and then made you go to bed by 8 p.m.?
Hmm.
No one wants to live
And
that
you have
way.
80 years of being independent prior to that,
Yes.
right?
Yeah.
Like you have all these memories of being an independent adult. It's like,
Yeah.
you're being treated like a kid, and who wants that? Yeah,
Right.
exactly. Exactly. I mean, it's such a huge piece. And that's part of the like thinking more in terms of like what might have happened that led to that reaction versus what's wrong with them, for example, which is also kind of
Yeah.
silly because if they have a TBI, you know what's wrong with them. Their brain is is injured. Like that's a pretty given. Of course, their brain's not working like a regular adult brain that you would expect. It's not working like their old brain either, which is probably tough if you remember being some way, or maybe you don't remember being some way. But yeah, that's part of that. Like, I'm really big on like trying to unpack the dehumanization. I think that's one of the biggest
Mhm.
pieces that I think we all tend to inherit is that idea of like if we see someone behaving outside of norms, we think that person's not really a fully deserving human, right? There's this automatic knee jerk, like, well, if they're throwing food, I'm not helping them. And it's like, well, was that about you or was the food throwing something else? Because if you take it personally and then you use that as a reason to like dehumanize the person and say they're being a child or something, like that is
Yeah.
like infantilization or something, right? It's like, well, now how are you going to help them? Like, that's not, is that what they're feeling on the inside? Because it's probably not. They probably have something totally different going on. And you have to, it's good to step away, do what you need to do to calm yourself, right? We all have those days. There might be a day where somebody throwing it on your new outfit or something. You're like, really? Really? The one
Scrubs are
day?
for
Right? Is that,
scrubs.
yeah, that's true. Yeah, scrubs are great. Oh my God. Yeah. But right? Like it's like, all right, sure. Maybe you get a little like it's not great, but you can go calm down a bit. But that's the important part of us learning how to regulate ourselves. And then co-regulation, people use it with kids and autistic kids especially. It's a big thing in that literature, but I think it's great for TBIs. I think it's
Yeah,
great
I
for
agree.
it's great for dementia patients. It's great for everyone to be able to just bring on some of that rest and digest, which is like that
Yeah.
deep breathing, all that stuff just kicks the parasympathetic up a little bit. So it's just that bottom up, like you're just using that to kind of get that system on a little bit more. And I mean, I think that's the biggest thing too, is just to catch yourself if you have those when you yourself gets a little when you get triggered, it might be easy to like dehumanize someone else, right? It's easy to be like, well, forget them. I don't need that.
Well,
It's like,
when I was an outpatient, I had dimmers on the light switch because I did
oh
work with a lot
yeah.
of concussion and TBI patients, and my boss one day, ugh, she came in and she was like, why do you have the lights dim? That's inappropriate." And I'm like, "Well, because my patient has photophobia," and she was
Yeah.
a PT in charge of like 20 some 30 people and had no idea what photophobia was.
Right.
So
Right.
a lot of that, and again, it's not a diss on her. It's more of like a lot of providers don't come in with this neuro education. A
Mm-hmm.
lot of it is things that you're interested in, like you, and you seek
Mm-hmm.
out extra training and extra CEUs or extra just
Mm-hmm.
courses in general that are relevant to your practice and things that you're interested in and want to be more mindful of.
Hmm.
But part of our role too is if we are in that space is educating our colleagues,
Yes.
that multidisciplinary team. And that's what Caitlin said. I do not currently work with TBI, but are psychologists often on the team. Well, so typically it would be a neuropsychologist. Um,
Mm-hmm.
and to help advocate, yeah, but I think it's more of the education piece and support for those patients. And then to also,
Yeah.
a lot of times in like an outpatient setting, they do more of the neurocognitive testing so they can refer to speech
Right.
or refer
Right.
to other providers, like say if
Mm-hmm.
it's a question of dementia, they've got to go to
Mm-hmm.
the neurologist for that diagnosis.
Yeah, there
So,
can be. There are some, when I did inpatient TBI for a bit, we actually had a psychologist there that helped with family
yeah,
and patient, which was
yeah.
amazing. But I know that's not, is not
No,
always the most common in that
we had a
model. But yeah,
neuropsychologist and we did the stroke education together and the TBI
which is
education
great.
together. So which was
Yeah,
cool. Yeah,
absolutely. Yeah.
because I learned so much
Um,
from that.
oh yeah, it's fantastic. And one thing I will say that I think is really good for us in general to have in our practice that isn't, I guess, not as well known right now is mental health first aid. There's actually a
Hmm.
whole program now, similar to CPR, but the idea is if anyone's in a mental health crisis or they're incredibly dysregulated, you got that agitated patient, whatever it may be, it's just a model of how to help somebody calm down a bit, essentially, and to help validate and normalize their experience, which is a really big piece. That's the trickiest part, is being calm enough to be able to just be like, it is frustrating being here. I can see why you'd be frustrated being strapped to your chair. I mean, as
Hmm.
being, you're a smart, intelligent, independent adult. It makes sense you're frustrated. That makes total
Yeah, and
sense. I would be frustrated too,
that's
you
part of
know?
the principles of trauma informed care is acknowledging,
Yeah,
not judging, providing voice and
exactly.
choice. Um,
Mm-hmm.
and a
Yeah.
couple
So,
places that I wanted to mention have free trauma training that isn't it's not, super intense or anything, but like
mm-hmm.
Virginia has virginiaheals.org, HEALS,
Oh,
where
fantastic. Yeah.
it's grant funded and you can go in and learn how to do trauma screenings on different age groups.
Mm-hmm.
And then I think it's Oregon has one that's specifically for school-based providers. And if you like if you did a Google search of free trauma informed training or something,
Mm-hmm.
it'll pop up things like that.
Absolutely. Absolutely.
But I wanted to go back
Yeah.
to that one question as kind of our last question.
Sure.
I've heard that a lot of people are misdiagnosed with ADHD and it's actually PTSD.
Yeah.
Is that showing up with older kids or adults?
Ooh, possibly a little bit of both, I think. And it's kind of a messy spot. I mean, obviously, I don't diagnose ADHD because I'm not a mental health person, but I'm not a psychologist or anything. But I think it's tricky because you're getting into like, obviously, there's people who are missed with their diagnoses, because especially if you're essentially not like a middle class white boy, you were likely missed if you're talking 30, 40 years ago
Mm-hmm.
for ADHD type diagnoses and also autism as well. So I think there is that. I think there's also from my perspective, I think one of the things that happened after COVID shutdown is we all got really dysregulated and had some serious issues from either the social isolation or dealing with loss and grieving and the fear of a pandemic. I mean, that stuff can have a lot of stuff too. So I do think there are people who are seeking more mental health help in general because of that and maybe coming to these sort of diagnoses. But the other kind of funny thing about it is ADHDers also still experience a lot of like microaggressions and kind of internalized depression and stuff like that. So some of them can have trauma from that, in addition to possibly also having the ADHD bit. So it is tricky. I think it's more the mimicking of the attention bits in terms of feeling more dissociated or feeling like you have racing thoughts. For trauma, that might be more indicative of like more of a trauma response. For myself, I did mental health stuff for my trauma stuff first, and then I got a diagnosis later after I had regulated and calmed down, because my brain still very clearly is not the way you'd expect a brain to work. So that helped me to kind of parse those two things out. I don't know if I myself would have been able to parse them out if I had had unhealed trauma and didn't know about the ADHD. I don't know if I would have been able to parse them out back before I had a little more help with the depression anxiety side. A lot of women with ADHD, a lot of women get diagnosed with anxiety and depression before an ADHD diagnosis and get treated for that first. And I don't know if that's just an internalized depression thing. I actually recently put out I did a little response to the How to ADHD person on my YouTube channel, where I mentioned that about, I think that a lot of, especially women, ADHDers, we tend to learn to internalize a lot of the messages of you're lazy, you're not good enough, you're not organized, like you're failing at being a woman, basically. And I think that maybe is why it sounds like anxiety, when it's like, oh, if I don't get this report written today, something bad's going to happen, or I better do this or else. And it's like constantly have these racing thoughts of anxiety of the sky's about to fall if we let the shoe drop and we forget something, like a classic ADHDer. And it's like, I don't think it sounds like anxiety, I think, to mental health practitioners, but it's like, is it anxiety, or is it actually like that actually has happened? You've actually had bad things happen. And you have
Well,
had
that's
that
like
experience.
the
So it makes sense.
1950s, when women
Yeah,
got diagnosed with hysteria, because
exactly.
a
The
lot of
fetal
that
hysteria
was,
bit. Oh,
yeah, a
yeah.
lot
And
of
I
it
have
was
a podcast
hormonal.
episode on that too. I do have a podcast
Yeah.
episode on female hysteria, because that was something I found out about, that Freud, back in the day, he actually figured out, before he retracted it, he figured out that a lot of these women who were diagnosed with hysteria had sexual trauma. That
Yeah.
was his initial finding, and then he retracted it because the people in power were like, you don't tell people about
Or
that. Mm-hmm.
postpartum depression is lumped into
Yep,
that too. Yeah.
exactly.
Because,
Yeah. So
yeah,
our initial trauma history could have been with women with trauma, but because it got redacted and buried by the bureaucrats of the time, it ended up being the initial thing were vets. The World War One was the next time it
mhm.
got really studied. And, not too surprising, that's when it was affecting white young men. And that's when they decided to really study, what is this shell shock business? What is this? What's going on? But yeah, so I do have a thing on that too, because that was shocking to me. I was like, wow, I had no idea Freud actually figured it out, but then recanted. So all of his later stuff essentially came out of him trying to explain away what he thought he saw initially. So
That's
yeah,
craziness.
good job, Freud. But to be fair, the one guy who didn't retract it, his stuff just got buried. His career just like disappeared. Nobody wanted to listen to him. So, the system, it's a problem sometimes. But yeah, I know I could go on forever, but I know this is the end. um, but if anyone, feel free to contact me if you want to. If anyone has any other questions or anything, feel
Yeah, and
free.
it's Virginia Heals. I put VA because I live here, so I always abbreviate. Sorry.
Gotcha. Yeah, the
But
trauma
Kim,
insight.
thank you so
That's great.
much. It was so
Thank
good to see
you.
you, and hopefully I will see you soon if you're going to
Yeah.
be, in DC, hopefully in November, maybe.
Oh, I'm not sure. I'm not 100% sure on going to DC right now, but that's all right. I'm still thinking about it. Still thinking about it.
Yeah, it's kind of a
Uh,
weird area to be in right now, but
yeah, you
I'm s-
know.
I'm speaking, so here we go.
Oh,
But
hey. Well, yeah, that's true. That's a good point. I will probably know some people who are doing some awesome talk. So, that is more tempting. Right. Well,
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 it's
thank
great
you
to
so
see you.
much.
Yeah,
Good
for
to see you
sure.
too. Thank you.
And Kim, I'll be in touch, okay?
All right. Sounds
All
good.
right.
Thank you so
Take
much.
care.
Okay. Bye.